morning. I'm Dr. Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor for the University of Kansas Medical Center. Welcome back to Open Mics with Dr. Stites. Obesity can lead to serious health problems, whether it's heart disease, diabetes, sleep apnea, and yes, even cancer. But unfortunately, some people don't take nutrition and weight loss seriously until they develop a health condition. Today, we're exploring a study focused on the critical time period right after a cancer diagnosis, when patients are extra motivated to improve their health. If we coach those patients how to eat healthy and how to exercise, can they lose weight? This sounds like an episode of Show Me the Science at the end of September instead of the beginning of October. I think it's going to feel like that to you too. It's pretty cool stuff. And by the way, will that weight loss improve their outcome? Those are the key questions in what's called the Warrior trial. Warrior is an acronym for, wait for it, just kidding, weight management aimed to reduce risk and improve outcomes from radical prostatectomy. Warrior, they left out the P, I don't get it, but okay. It was conducted by physicians, dietitians, and scientists right here at the University of Kansas Medical Center. Results from the placebo-controlled randomized phase 2 trial were published earlier this year in the Journal of Urology. And today we're diving into what those results mean for both the doctors and the patients. Joining me today are two authors of the study. Dr. Will Parker, a urologic oncologist here at the University of Kansas Center. Complete transparency, he's my doctor. I have prostate cancer. I follow with this guy. When I started following with him, he had hair. So you can tell I've been a stressful patient. And Dr. Jill Hamilton-Reeves is a nutrition researcher who is also board certified in oncology nutrition. I should point out that they are two of the bigger people on a bigger team involved in the Warrior trial. So credit goes to the whole team. This trial would not be possible without people like Craig Urett, a trial participant and prostate cancer survivor as well, whose last name comes from Samaria, as I learned when I tried to get him to pronounce it for me earlier in this program. Okay, Craig, I want to start with your story. I understand you are checking your PSA because of your family history. I'm right there with you, brother. In fact, you told us that you were buying your own tests and taking them to a lab. What did you see on those PSA tests? And did you really buy them on your own?
I did. Request a test in Jason Health.
All right, and you got those, I guess, and you must have seen something on those PSA tests. What'd you see?
Well, my father died of very aggressive prostate cancer. And so from some form of osmosis, I had an inner calling that I had this. And you get one a year through insurance. So Dr. Killen at KU, I explained to him, got it, put me on Cipro, and went to my dad's urologist and found out how explosive it was.
Okay.
So from
you
there,
must have seen something on the PSA tests that were a little bit elevated.
It actually went down, but I would have a symptom, and then I would go down and QR code my scan, and I would get a spike. So that's when I started dope charting.
Yeah.
And what it was my symptom and my result or difference. Yeah.
So why did you decide to switch care to the University of Kansas Cancer Center?
Dr. Darren Killen, my primary physician. And
you said go see that guy.
Well, yeah, I was set to go see Vip Patel.
Okay.
And I got the nurse navigator that just was like an angel. Walked into the cancer center. I met this young man that, how can he be a cancer surgeon running a robotic? I had done the bio on him, the Mayo Clinic, and chose him at the end of this, and that is, hold your hand up and let me see it. And he looked at me and held it out.
He looked rock steady, stable, didn't he?
You gotta have that to be a, gotta have that to be a surgeon.
I am not a surgeon. You don't want me to be, but I can hold my hand steady.
But you can do it, right? I love it. I love it.
So, do you remember being asked to participate about joining the Warrior trial?
I do.
And why'd you do it? That sounds like a lawyer. I'm cross-examining.
Yeah, no. To anything I can do to help anyone.
That's awesome.
in their human experience.
And so what do you recall from the exercise and the nutritional coaching?
Hillary with the plastic food. And
Plastic food. That sounds really good. Right?
it was funny because you retro back like a child, but it made so much sense because
I go back to like fast food, but I'm not going to name any vendors.
Yeah. And so what she's telling me as a portion is basically a bite. Yeah. And so we laughed and we went through it, but it did galvanize and it did resonate. And I do want you to know, for breakfast today, I ate a white peach from Canada, and that's
awesome. And I love that you know the nationality of the peach. That's
right.
Okay, now fast forward to the day of surgery. You talked about Dr. Parker's hands, calm and steady. 4 years later, it's been 4 years. How are you doing?
0.01.
Awesome.
Yeah.
I like that.
Undetect.
And we're going to talk about what that means, right?
Yes.
What does that mean, Dr. Parker?
It means no sign of cancer. So no evidence of disease, cancer-free at this point, which is great.
Yep. Thank you, bro. Thank you very much.
Yeah,
Thank you.
He is pretty good. I have to give
He's
him credit
awesome.
for that. So let's talk a little bit about the Warrior trial. Dr. Hamilton Reeves, this was funded by the American Cancer Society. What does it mean to have their support?
Oh, it means the world. As you know, finding research funding is difficult.
It is.
And even more difficult for lifestyle trials and nutrition interventions because there isn't a pharmaceutical or the money-making aspect of it.
You bet.
And so there are limited options for the kinds of funding that we can get. And yeah, I am indebted to their support. And it's really neat to see how the people that donate, how their money does go to work. And and I'm very appreciative.
That's awesome. Okay, guys, so you're going to have to tell us, two of you, how does obesity affect prostate cancer? And I think there's some slides out there for us to take a look at.
Yeah, so I mean, I'll let Will talk about more the proximate things like during surgery and how that affects surgery. But as far as the scientific lens, there's data associating especially abdominal obesity and fatal prostate cancer. And then also gaining weight after a prostatectomy is associated with the recurrence of cancer. Okay. And so that's really kind of the space we were looking into to reduce that risk.
All right, so who thought about that idea? That's interesting, prostate cancer and obesity.
Honestly, it was Jill and Jill's team that came up with the concept.
Oh, well done. That's awesome. And so does it affect surgery too, the obesity?
It does.
Yeah.
So people who carry extra weight, particularly, again, going back to abdominal obesity, we're talking about surgery that has to go through that part of the body, and it makes the surgery much more complex and much higher risk. So the risk of complications afterwards, and it takes a lot longer to recover from the surgery when you carry extra weight. So things like incontinence and erectile dysfunction are worse in men who carry extra abdominal weight.
So they don't carry extra abdominal weights, what I'm hearing. I
Correct.
gotta go back to the gym. Oh, gosh, I was at the gym this morning. How did you structure the trial?
Well, given this relationship, you mentioned at the beginning that when people have a new diagnosis, all of a sudden they're very motivated to change their health. And so in talking with Will and thinking about what makes sense and what's convenient for our participants, we found out that patients have to wait for their surgery anyway. So they're sitting with that anxiety. And we know that being healthy and exercising can help people cope. And so that's when Misty of my team would call up people and say, hey, you're eligible for the study, are you interested? And we help people learn how to lose weight before surgery. And that was really where it was more aggressive. We met with you a whole bunch more. But then, as I mentioned, if you gain weight after surgery, that can reduce the risk of recurrence. So one thing that's very unique about our trial design compared to any others out there is that we did a weight maintenance for 6 months after the surgery, just to make sure that we keep the weight stable. A lot of the guys actually picked up some momentum after surgery, and they continued to lose weight. So that's how it was structured. And a lot of it was using an app where we communicated with you and televideo, because this was during COVID times as well. So yeah, there was a lot to it.
That is a lot. And so how did people do? I mean, can you tell from the study? I think we had a graph showing the percent weight change by participant. And how did that go?
Well, the weight change speaks for itself, but I think some of the more exciting things is that the visceral adipose tissue was significantly dropped in the intervention group. And then a lot of markers, biomarkers that we measured in the blood, they also responded to the weight loss in a way that's favorable for disrupting that cancer and obesity link. And so very favorable findings. Yeah.
That's pretty cool. So did you put him on a peach in the morning from Canada? Is that, was that your doing? Because you're also a registered dietitian, I'm assuming. Is that right? Yeah.
I am credentialed as a dietitian, yes.
And you put him on a peach from Canada?
Well, we talk a lot about fruits and vegetables, and you know, the thing with a behavioral intervention is if I tell someone what to eat, that's not going to work. But these guys had a peer support group that we built within the study, and they would say what fruits and vegetables they ate and shared ideas with each other, and that seems to be a little bit more effective.
Okay, well, there you go. Fruits and vegetables are a good thing. This is kind of the Mediterranean diet thing, I'm going to bet. Is that right?
It was actually more high protein, high fiber,
Okay.
because that helps people feel full. We really want to keep muscle on because, as you know, with cancer and all of the treatments that could be coming down the line, we're not saying it'll come back, but all of those treatments can wear away muscle. And so we want to do what we can to preserve muscle all along the way.
Okay, so high protein, high fiber. What are the limitations of the trial?
Well, there's a couple of really obvious ones. So you know if you're following a lifestyle intervention. So we had an active control where they, of course, got standard of care. They also got materials about what kind of nutrition things to do and what kind of exercise. So they could do this on their own, but they didn't have the support of the intervention group. So it can't be blinded. That's a problem.
You bet. Losing weight isn't blind. I think that's okay, though. That's
yeah, it's kind of inherent to the design.
Yeah.
The other thing is that it's a phase 2 trial. And really, to be able to change practice, we need a phase 3 trial. And so I have gone to a cooperative group with Will as my partner, and we're actually approved to move forward to build a phase 3 trial.
Awesome.
And it is a long haul, though.
It is a long haul. Phase 3 trials are hard, multi-center, doing a lot of stuff.
Yeah.
That's a great, but look at the great outcomes. So, Dr. Parker, what do you think about this whole approach? Nutrition and cancer, what are your thoughts?
Well, I mean, first off, I think the science is going to be really exciting once we start to know more about how some of these changes at a molecular level are going to affect the cancer. But when I take it at kind of more of a face value, the window of time between surgery or from diagnosis to surgery is an ideal time to actually start doing some interventions for weight loss that actually work. We prove, as proof of principle, men can lose weight in the 6 to 12 weeks before surgery and keep it off.
That's what I just heard. Men can have willpower.
Correct.
That's awesome. And so one of the things that have been in the press a lot lately has been about the bad effects of even mild to moderate alcohol consumption. Thoughts about that?
Yeah.
I know that's not a script.
I feel like I popped
You're like, where's that question? I can't remember. But you're really smart, so you can do this.
Yeah, I mean, I think it affects so many things besides just the biology, but also the mental health aspects and coping and resilience. And so, yeah, I do think that
I think there's something to this that I'm a little concerned about. Now, I don't actually drink very much, but I would be concerned because that's such a different message than had been out there. Well, moderate may be good. I mean, you had to drink a couple of glasses of wine. That's okay.
Yeah.
Well, maybe that's not okay. And so far, that uncertainty can be a little bit hard. So, okay, so we've talked a lot about some of the things within the trial. Anything you want to tell us, like the results looked really cool? Is that kind of what the message is here? Can you tell us that, or is that you can't tell us what phase 3?
So I would say the results did look really cool.
Yeah, awesome.
So fat metabolism, so how we process fat is known to be related. And Will, with his amazing hands, he was able to get us, and this might be a little bit detailed for you, but the fat around the prostate gland. And so we've been able to study that and look at how signaling is changing. And we think that some of that fat around the prostate gland is actually responsible for some of the biological effects for enabling the cancer to spread to the rest of the body.
Wow.
So having this
That's
partnership
really amazing.
with a surgeon
Yeah.
to really be able to focus in locally on what's happening. We've partnered with a company that is doing a deeper dive into the prostate tissue and all of the molecular changes. And so, yeah, I mean, there's more to be learned for sure.
But that's a big darn deal. Now, Craig, how has your cancer experience changed how you approach your health?
It's a great question, and thank you, because honestly, I just completely, totally gave up alcohol.
Yeah, that's a big, and that's a change.
Well, yeah, it is, and you know, it's just a conscious, positive change of, you know, realizing that your age and, you know, is this a vice or is it not a vice? And, you know, I'm responsible for my own health, so you know, I don't miss it.
Isn't that interesting? You know, Budweiser may give up their sponsorship of our program.
Yeah, right.
I think, you know, on the other hand, you know, the healthcare is
they may
pretty
not
good.
fund my research either.
There is a blue moon,
Yes.
and on the blue moon, you know, is the single malt Lagavulin.
I like it. There you go.
You know,
I think
so,
the blue moon is okay.
Temperance, yes. Yeah.
Yes,
Oh.
yeah, it all works. All right. Well, we are here to answer your questions. Send them to us using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's check in with Doc Hawk. Doc Hawk, the inpatient COVID numbers, not what we want.
No, I thought when you were here we were supposed to have low numbers. That is not what we have.
Yeah.
So we do have a point in time. We have 20 patients with positive COVID tests in the hospital here at the KU Main Hospital. So unfortunately, we were hoping that number would go down. We believe, and certainly all the data would support the fact that there is probably less circulation of virus in the community now compared to 4 and 8 weeks ago. But still, obviously, it is out there. Unfortunately, we are really entering into the respiratory viral season. We will have to see really how the circulation changes, if there's going to be more COVID cases coming in the next couple months. I know we just kind of came off of a peak of COVID, but then also we have RSV and influenza as well. So we'll keep everybody updated. And again, luckily in November, we start reporting mandatory, hospitals are now mandatory reporting to CMS as well. So we'll have a lot better data to track as well.
So as the new COVID vaccines roll out, we're seeing the same old rollout of misinformation. And what's disappointing, this involves the Florida Department of Health. They told older Floridians, and I don't know why this would only apply to older, but okay, older Floridians to avoid the mRNA vaccines, claiming they are potentially dangerous and could threaten the integrity of the human genome. That is simply false. What's worse is at one point in time, you could trust that politicians wouldn't erode into health to try and manipulate the information and just lie. And that, unfortunately, that erosion has occurred again and again throughout COVID. Hawkeye, what the heck?
Yeah, just some poor shepherds for the flocks there down in Florida for sure, for many reasons.
Well said, by the way.
Especially for medicine here. Again, there is no evidence, there's no data to support the fact that this mRNA, modified RNA vaccine, integrates into the human genome. They are really completely different molecules, RNA and DNA. The RNA gets broken down soon after injection into the body and after it's been utilized to create that immune response. So completely false. But we do know it's safe.
We're going to get our vaccines here in the program pretty soon.
Yeah.
I think in a couple of weeks, I think.
Absolutely. Remember, if you have had COVID recently, you can wait about 3 months before getting this new updated vaccine. Obviously, influenza vaccines are available too, and like you said, we're going to be getting those. But with that, talking about the COVID mRNA vaccine does not integrate into your human genome, into the DNA or anything like that. But what is important, multiple studies have shown that the vaccines are extremely safe, but we also have real-world effectiveness data on the updated vaccine from last year. So the 23-24 updated vaccine, which I believe was the XBB.1 monovalent vaccine, we do have real-world data to support that. So vaccine effectiveness, VE, against even just infection or symptomatic illness was quite good. It reduced your chances, reduced your risk of getting symptomatic illness or infection by over 50% soon after the injection, and of course that protection wanes. So that is one of the unknown benefits, or really unrealized benefits of the vaccine, is it does help reduce your risk of infection. But that is not the main goal of these vaccines. The main goal is to reduce your chance of disease, and especially severe disease. So we have real world data on vaccine effectiveness against disease as well. And this includes your risk of going to the hospital or going to the ICU. So in the real world, again, this is from data from last year's updated vaccine. We see that there is fairly high reduction in risk, 43 to 66% for all age groups with reduced risk of hospitalization. But also, if you are immunosuppressed, and those are the people that are most at risk, and those are also the people that may not mount the best immune response. But even there, we had about a 40% reduction in risk of going to the hospital as well. So we do have an added benefit of reducing risk of infection and symptomatic illness with the vaccines. We know that they have a very good effectiveness at reducing risk of hospitalization, but there are also other studies supporting the fact that the vaccines can help reduce your risk of long COVID, thromboembolic disease, which is basically those blood clots in your lungs or your legs, and then, of course, cardiovascular complications like heart failure and things of that nature. And again, we know that people are concerned about the myocarditis that occurred in that certain age group, which was those boys about 18 to 24, those young men. But when they did that large study, they showed that those myocarditis findings and changes were much less reduced than if you got the myocarditis from actually getting the infection. So again, plenty of real-world safety and effectiveness data for these vaccines.
Yeah, the misinformation is concerning because it flies in the face of the fact there's multiple studies now from all across the world showing the effectiveness and the safety of the vaccine. There really is no question left to doubt anymore. If you're not going to take the mRNA vaccine, what the heck are you taking the polio vaccine for? What the heck are you taking the influenza vaccine, the hepatitis vaccines? I mean, come on. At some level, you have to give up the silliness about this and quit trying to erode the truth. Hey, last week the FDA approved the first ever self-administered at-home flu vaccine known as FluMist. Doesn't look like it's going to be ready for this flu season, though. FluMist nasal spray, live intranasal vaccine, approved for 2 to 49. Okay, why the age discrimination, and what do you think?
Yeah, I mean, again, I think this is historical. FluMist, the live vaccine, which is squirted into the nose, is not a new vaccine. It's been around for some time. And that has been the historical approval. We'll see if, when the changes are made, and they do anticipate by the influenza season of 2025, 2026, that this will be available for home use. Again, it's a live virus vaccine. Another example of a live virus vaccine is measles, mumps, rubella, MMR vaccine, but again, that's an injection. This is a nasal nasal mist that you squirt into your nose. So I think we are hoping this will be good and prove more access to vaccines for people, especially those at risk, to try and keep everyone safe. But again, a prescription will be required, and it really is not anticipated to be available until next respiratory viral season.
All right, we know many of you have questions. Thanks, Doc Hawk. Let's head to Studio B with Alexis. Good morning.
Good morning. We have a really good question to kick things off from Jeremy Yenser. Jeremy wants to know, is it something about the state of being obese itself, or is it the lifestyle or the genetic factors leading up to obesity that cause everything to be so much worse health-wise?
Wow, that's just a great darn question. What do you think?
Yeah, so I would respond by saying it's all of it. However, there has been a focus on studying obesity and cancer and the link behind that, and there seems to be some direct effects that are related to chronic inflammation, some signaling changes in the cancer itself that are directly linked with obesity and cancer. But as you point out, being unhealthy going into cancer treatment is hard on a person. So building up your health and being as strong and resilient as possible leads to the best outcomes. Do you have?
Yeah, I would agree. I mean, I think one of the key things from that question, I think that kind of underlying is obesity is something that even if there are some genetic predispositions that are leading towards that pathway, there are things that we can control from a lifestyle standpoint that we should focus on. So even if I'm predisposed to some condition, if I can take part of that under my own control, I should.
Yeah, I think that's really the key. We have to recognize that obesity is a public health disease. It's been linked to many different things. Yeah. As you get older, your BMI changes a little bit, I think is fair to say, as I've experienced. But the other thing we know is that obesity affects so many, it affects asthma, it affects heart disease, it affects cardiovascular, neurologic disease. and cancer. It shouldn't surprise us as something that's unhealthy is unhealthy in a lot of different ways.
Yeah.
Yeah.
Yen Liang has a question, and it's also about weight. He wants to know, he says there's a rumor that once a person reaches middle age, they shouldn't be too thin, and that sometimes being too thin can be risky if they get sick and need to be hospitalized for a long time because they might lack the physical reserves like fat and muscle. Today's topic talks about the importance of moderate weight loss. How can we find a balance between those two things? And is that true? That you shouldn't be too thin?
And I just made a reference to that, so let's talk about that. Does your BMI scales are all really based historically on young people?
Yeah.
As we get older, what changes?
Yeah, so, and BMI isn't really the best
It's a terrible
indicator.
measure. Let's be honest.
Yeah,
Right?
okay, it's actually
measure.
quite awful, and I just
Yeah,
didn't want to
yeah.
be disrespectful.
No, you're not being disrespectful, and I'm glad you're telling the truth.
And you bring up a really great point, and something that is sometimes a challenging message, public health message, is that there is a kind of a Goldilocks, right? Like you don't want to be too thin and too lean, and you don't want to be too big and overweight with too much extra body fat. And where that sweet spot is actually differs person to person. And so helping someone find their healthy stature and body composition and where they feel good, that's actually the sweet spot.
Yeah.
It's not a science feeling, but when you get there, you know it. You feel good in your body.
That's a great piece of advice. And our bodies change because we do lose some muscle mass as
Yeah.
we get older and gravity starts to win. So we're not going to look the same in the mirror. And if we pursue trying to look like we did when you're 60, when you're 20, that can make you unhealthy, I think.
Right, absolutely, yeah.
All right. That's a great question. Young Lang always asks the best questions.
Jean has a question about vaccines. Jean wants to know, is there one of the vaccines, the brands that you favor more, or is it better to mix the vaccine manufacturers, or is there no difference?
We get this question a lot. We did, especially in the midst of the severity of the COVID pandemic, Hawk. I think I'm not too particular. How about you?
Yeah, so I think that's exactly right. The recommendation is any of the vaccines that are available, and right now there are 2 mRNA vaccines, which is produced by Moderna and Pfizer, and there is that protein subunit vaccine, which is produced by Novavax. CDC recommends either of them that you can get. That's going to be important, and there's no recommendation to consciously mix them. But if you are able to get one, any one of those is going to be protective for you.
I think the best one is the one you're going to get.
Absolutely.
That's
Absolutely.
the best one to do. Hey, this has been a great discussion. We could be here all day long. Our time's up. I'm grateful, though, to our guests for being here. I want to hear final thoughts before we go. Craig, thank you for being on the program. Outstanding job, and congratulations at being 5 years out. Is that what I remember? 5 or 4?
5 February 14th.
Awesome.
Yeah.
That's awesome. Congratulations. Final thoughts.
And thank you all for having me here. And I learned a lot on the vaccines, really,
Yeah.
that it's being politicized, and I've got the head of infectious disease at my side giving me an education lesson that I've galvanized, and I'm going to go get my my shot.
All right, you go do that. That'd be awesome. That'll help protect you
Absolutely.
against
So
cancer.
thank you. This has been wonderful.
Yeah.
And thank you for what you all did during COVID.
You bet.
And in particular this setting.
Well, we're happy to serve, and that's part of being in medicine, I think. Dr. Parker, final thoughts.
I think common theme, taking control of your health, take ownership of the things you can control, and we'll help with the rest.
Doc Hawk, sorry, Dr. Hamilton Reeves. You both have H's in your last name.
I know, that's very
Confusing to me.
confusing.
Yeah, okay.
Yeah, so I mean, just echoing what Dr. Parker said, and then adding in to not be afraid to ask for help. Making health changes can be challenging, and having someone in your corner to help with those changes can really make all the difference at a time that, if you're facing a cancer diagnosis, can really be overwhelming.
All right, thank you. Thanks for being on the program. Come back anytime. We don't have to have him. We'll have you. That's awesome. We talked about that. So Dr. Hawkins, some final thoughts.
Yeah, just another great story, and I think it just adds to just the multifactorial essence of who we are and what we are in our health. That is maintaining good nutrition and body weight, good rest, as we have talked about. Get those vaccines. They will help protect you and keep you reduced illness. And then, of course, just having your friends and family around will help your emotional state, your physical state, and your mindfulness as well.
Yeah, awesome message. And I think I'm like 5 years out, aren't I? Something like that. It's been a while.
Yeah, it's been a while.
I'm getting old. Watch out for that. Hey, listen, every time we talk on this program, we talk about the importance of faith, hope, and science, and how when you put those things together, what a miracle that can help produce. And I think, every day in medicine, you witness little miracles that add up to really major improvements in what we can do for people. And I think the research you've touched base today, it's like a little miracle. And what great information, what great news. Thanks for being on. Thanks for all the great things you do. Good hands. Thanks for being willing to come up and tell your story. Thanks to Doc Hawk for sticking with me for all these years. Hey guys, we'll see you next week. Thanks a lot.
When she was diagnosed with breast cancer, she didn't slow down, she got moving. I'm Alexis Del Cid. On the next All Things Heart, her doctors say it had everything to do with protecting her heart during her treatments and her recovery.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.